Our next speaker is Dr. Sincere McMillan. Dr. McMillan got her nursing training initially at Stony Brook here in New York, at Delphi, NYU, and she's been on to get her Doctor of Nursing Practice at Walden University, and she's also a trained geriatric nurse practitioner, and that's what she practices at Memorial Sloan Kettering Cancer Center. She has been very, very active in this field of geriatric oncology. She is has a wealth of research behind her name and grants as well. And she really comes to bring us to the next level here. We talked about cancer prevention and cancer treatment, and we move now to the point where when everything else fails, what happens to the patient. And she's going to focus specifically, though, on geriatric cancer considerations, not palliative care in its full array, but she's going to be very specific about what she does and give us an understanding of what happens at this level, where the elderly with cancer and with oncologic problems need assistance beyond the medical stuff that we do. She will touch on that as well, of course. But here she is, Dr. Sincere McMillan.
Thank you so much. Thank you so much, everyone. And I really just want to say thank you for the warm invitation and the greetings that have been extended so far. As was stated, my career right now is focused in geriatric oncology. And so this is the care of the older adult with cancer. And I'd like to, in your hearing in the next few minutes, talk about some considerations for this population. So here are some objectives. Essentially, we're going to walk through the relationship between cancer and aging, which has already been outlined very nicely by some of our previous speakers. Some clinical approaches, we'll talk about that for those patients who may be at the end of life. We're also going to be talking about palliative care and how that actually impacts clinical practice. And then finally, again, focusing on the adult with some end-of-life considerations. So this graphic speaks to the fact that as we age, our risk of cancer also increases. It doesn't mean that every older adult gets cancer, but what you'll see is that, especially over time, we're seeing more and more cancer in older adults, and especially amongst what I'll consider the older old, right? So if you break up the population of older adults, if you think about it from 65 onward, we're seeing a lot of cases of cancer. And that makes sense because as our previous speaker stated, as we get older, there are some vital functions of our body that change. And so that can put us at risk of cancer. I'd like to introduce actually a case study because this will kind of frame our talk as we move forward. I'd like you to meet Mrs. C. She's 79. She has a past medical history of many comorbidities, including metastatic colon cancer and COPD, which is a stage 3. And for those who may not be familiar with stages of COPD, it's a pretty significant stage. Stage 4 being kind of like the last stage. But she's been hospitalized 3 times in the last 6 months for COPD exacerbations, with the last hospitalization that she was actually admitted for being particularly difficult due to something called delirium, which is an acute change of a mental status from someone's baseline, usually in the face of something like an infection or multiple hospitalizations. So not only did she develop delirium, but significant functional decline as well. There are no further planned cancer-directed therapies due to her declining status, which is not only from the metastatic colon cancer, but all of the other comorbidities that she actually has. So when we talk about caring for the older adult with cancer, the reason why we kind of focus on this population is because we want to make sure that we're giving the right therapy to the right person. So it's no longer kind of like in vogue to just look at somebody and say, oh, because you're an older adult, you can't get cancer-directed therapy. Or because you are an older adult, we're only going to give you a certain type of therapy. What really is the standard of care now, if you look at ASCO guidelines and NCCN guidelines, is to really target the care, the cancer-directed care, to that particular patient. And the way that we do this in such an individualized way is by using a tool like the comprehensive geriatric assessment, which not only looks at the cancer, but looks at all of the other factors in relation to that older adult. So what environment do they live in? What's their social support like? What function do they have, right? Because you can have an 80-year-old who's skiing, right? And you can have an 80-year-old who's in a wheelchair, right? They're both 80 years old, but their level of fitness is different, which could also translate into their ability to tolerate cancer-directed therapies. We also want to take into consideration other medical comorbidities and cognitive status. So when we look at the comprehensive geriatric assessment in the context of caring for the older adult, we're really trying to risk stratify our patients. Where do they fall on the fitness versus frailty spectrum? So if you think of a part of aging as being a spectrum, where does that person fall? And that will also help us to determine, okay, what is somebody's life expectancy? Even in the face of not having cancer, if we have an 80-year-old, again, who's kind of skiing very functionally fit, does that look different than the 80-year-old who's more on the frail side? And if the answer is yes, and if we think intuitively that is yes, then when we add the cancer to the mix, how does that help us to determine what treatment is right for that particular person, right? Because as our first speaker said, there are cancer therapies that have multiple drug or immunotherapies that are involved, and then there are some that are monotherapy. So we again want to make sure that the right person gets the right treatment and not based on age alone. But in the case of Mrs. C, there's an elephant in the room, right? And I think this is where we as clinicians, we as advocates, we as family members and caregivers really have to take a look at the person as a whole and say, where is this person on this trajectory of fitness versus frailty? And that's where we bring in what's called palliative care. I'm going to talk about hospice in a moment, kind of like as a separate trajectory, but in terms of palliative care, really the goal of palliative care is to affirm life, and it regards dying as a normal part of the process of life, even without cancer, right? We are all on a trajectory where we want to have good quality of life, no matter how long our lives are. So palliative care is not really meant to hasten death, but it's also not meant to postpone death. Really, we want to integrate all of the aspects that make us human into palliative care and build a support network around that patient and their family and caregivers using a team-based approach. So when we look at previous palliative care models, essentially what we used to do was we try to prolong life as long as possible at any extent or cost to the patient or family. And then when we got to a point where we said, okay, there's really nothing more that we can do medically, we would refer somebody to palliative care or maybe hospice. And they would only have a short amount of time in those services or programs before they actually met their demise. And so they really didn't have the benefit of having palliative care involved. Newer models are actually saying, okay, we can focus on life-prolonging care, right? With all of the new interventions and all of the treatments that are coming out, there's no reason why we shouldn't focus on life-prolonging care. However, let's incorporate palliative care earlier in the trajectory so that we are, again, affirming life, managing symptoms, and helping the patients live a better quality of life. And then when we get to the point that we're saying, okay, we've exhausted medical management, or in the case of Mrs. C, with multiple comorbidities and multiple hospitalizations, we're addressing the elephant in the room and saying, yes, we think that this person is or could benefit from end-of-life care. We bring hospice on board. And even after the patient expires, we still provide bereavement services to their caregivers and their loved ones, because we know that it doesn't end when that particular person has breathed their last breath. So going back to what palliative care is, it's active, it's holistic. It really is for all ages, for persons who have serious health-related conditions, and that does include cancer, and especially for those at the near the end of life. So you'll see here some of the goals. I won't read through every bullet point, but really improving quality of life, preventing suffering, and treating pain, not just physical, but psychosocial, spiritual, emotional pain as well. So as I mentioned, palliative care, if you think about it as a sphere, hospice is a part of that sphere, but it's not the entire sphere. Sometimes I've come across, even in my own practice, where if I mention palliative care, people think automatically that I'm talking about hospice, and it's not the same. So we'll talk about hospice shortly. There is an urgent need for palliative care, not just in the US, but globally. So the World Health Organization actually estimates that every year, over 56 million people are in need of palliative care, most of whom live in lower and middle income countries. And I think this is a really important point to drive home, that these services should be available to everyone. 90 million Americans are actually living with a serious illness, and this number is actually expected to increase. And almost half of Americans have not had discussions about what they would like the end of their life to look like with anyone, right? And so this really shows that there's a lot of room for us to get better in the palliative care sphere. So again, for sake of time, I won't read through every bullet point, but you may be asking yourself, how do I know when palliative care is right? Or how do I bring up the topic of palliative care if you are a clinician? Well, you can look at a couple of things. You can look at the presence of a chronic illness, some of which are listed here on the slide, including cancer, even without metastases. You can look at the functional loss of a patient. So for example, with our case study with Mrs. C, we noted that after her hospitalization, she had significant functional decline. So if you have somebody who's more dependent on caregivers or hired attendants at home to maintain their inability, their ability to kind of function, that can be another reason to kind of use as a gateway into the conversation of palliative care. And anybody who has unmet needs, so not just symptom management needs, but also guidance with healthcare decisions, or somebody who's had frequent hospitalizations, these are also really appropriate time points in which to enter palliative care. How do we practice palliative care? Well, essentially, it is a team-based approach, and we really want to be collaborative when we are talking about palliative care. We want to make sure that the patient stays at the center of the care, that we can help them elicit what their goals are, but that we also bring in, again, all of those human aspects, the spiritual, the emotional, the psychosocial, the medical, to really help maintain dignity of that person and their family. The reason I have a seatbelt here is because, again, I get asked the question, well, will palliative care or the discussion of palliative care erode hope? And it's actually a very good question, but I say this to you in kind of response. When you put a seatbelt on, do you think that, oh, I'm not going to get to my destination safely? 9 times out of 10, that's not even in your head. You're just thinking, I'm doing this to protect myself in the event something happens. And so I think that's the way we should start framing the discussions of palliative care. And it's not saying that something is wrong or something bad is imminent, but what do you want things to look like for you? And I think it's very empowering for the patient, especially if they have the ability to participate in these conversations. So how we start the palliative care conversation can look different. It will depend on the patient. It will depend on their culture and their background. It may depend even on family dynamics. But one tool that I have found very helpful in my practice is the SPIKES tool. And SPIKES is actually an acronym, and it helps us to deliver bad news. And we can actually apply it to the cancer setting. So here's what SPIKES stands for: setting up the interview. So making sure that we are in a place where we have the time as clinicians and caregivers to dedicate to having these conversations with our patients and loved ones. The perception, right? So tell me what you understand about your diagnosis or what you understand about palliative care, because this is the opportunity for us to really kind of identify gaps and to eradicate any misconceptions or perceptions. Invite the client or the patient to share information, right? Before we start to kind of elicit and give all of this kind of like medical things to them that could be overwhelming, really to invite them and say to them, hey, are you ready to have these conversations? Sharing knowledge, and this goes both ways, responding to emotion, right? If we're going to really be giving somebody information or news that we would consider, I'm going to use this in quotes, bad, then we really have to give them space to process that emotionally, even if that means we're sitting in silence with them. And then finally, summarizing the discussion and leaving room for next steps and further conversation. So some strategies to communicate with patients, and I can also say this for loved ones, because this has helped me when I've had goals of care discussions, is to make sure we're speaking the same language. Outside of being able to speak English, right? Which even if English is not somebody's primary language, we can definitely make sure that we have interpreters to make sure that our communication is good. But also making sure that we're looking at nonverbal cues, making sure, and I speak to, as a clinician here, that I'm not running the show, right? That the patient and the family are really, again, at the forefront of the conversation. So using more open-ended questions, seeking clarification and allowing space for the patient and family to do that. And again, using silence where it is appropriate. A key point that I always like to talk with my patients about, irregardless of age, but especially among my older adult population, is appointing a healthcare proxy. I think this is one of the single most important things that we can do as a clinician, because the healthcare proxy, when the time comes, is the voice for the patient. So the patient can appoint somebody who can speak for them in the event that they cannot speak for themselves. It can be a family member, but it doesn't have to be a blood relative, just somebody that that patient trusts and somebody who has the ability to speak on that patient's behalf. There are even some healthcare proxy forms that will allow the patient to write in their wishes so that, God forbid, that healthcare proxy in the middle of everything happening doesn't understand or remember what that person says. It's clearly written down. So now speaking about hospice, which again is that extension of palliative care. In the United States, hospice is actually a covered entity. So for older adults who have Medicare, for those who have most commercial insurances, it is a covered benefit. Essentially, to enroll in hospice, there needs to be a prognosis of 6 months or less if the disease were to take its natural course as determined by a clinician. The patient must be willing to accept comfort care or palliative care and forego kind of like the regular services that are more treatment based towards a cure. The primary goal is quality of life and symptom control, and hospice can be provided at home or in an inpatient facility if somebody is more acute or the needs are more acute. At the end of life, symptom management and pain control are of paramount importance. We really want to focus on a stepwise pain management approach. And if somebody is on home hospice, this can be done by a caregiver or family member, but they're not doing this alone. This is in the conjunction of hospice trained clinicians and staff who are there 24 hours. The goals of at end of life are to relieve suffering and address emotional and spiritual distress. I've had many patients who are at the end of life and their family members are asking me about things like feeding them. Is it safe to do so? Should we do so? So I do just want to highlight that there are significant shifts in what our body needs when we transition towards the end of life. And so whereas, food has a very cultural tie to it, there are some patients who continue to eat, but may eat less, and there are some patients who don't eat at all. And that can be challenging to watch, but the patient is not suffering. Their needs have changed, right? And so also another point that I want to bring out is cognitively. Some patients at the end of life can develop cognitive changes which would include cognitive decline. This can be a normal part of the process. And I always encourage family members to, as much as they are able, to be there, to reminisce with the patient. Even if their eyes are not open, I do believe they can still hear. And so making sure that, if there's anything you want to say, music that you want to be played, prayers that you want to be said, that you do that at that time. And again, once the person has passed away, hospice care doesn't stop. You as the caregiver or a provider, or even as a clinician, right? Because we can become very attached to our patients as well. There are spiritual, physical, emotional needs that extend beyond that person that has passed away. And so hospice really, among one of its vital services, is grief counseling and bereavement support for family members, caregivers, community members, so that they can find meaning and actually be able to move forward through the stages of grief and loss. So in conclusion, I just want to highlight that knowledge and confidence of the concepts of palliative care are vitally important for clinicians, family members, caregivers, and patients. Our goal really is to advocate for the patient, and really, as clinicians, I think one of the best things we can do is to start conversations. They may not end with us, but if we plant the seed, somebody else can water that seed, and hopefully the patient gets what they deserve and what they want at the end of their life. So I thank you so much for your attention, and I know we'll save questions for the Q&A. So I will turn it back over to the moderator. Thank you.
Thank you, Dr. McMillan.